welcome once again to our listeners of this particular MOOC module on health economics. I am quite sure that you are getting certain directions to understand the entire module after reading important 3 chapters on especially the background understanding, then demand for healthcare and of healthcare. Of course, another directions to this module would be on uh, equity in healthcare, and it has linkages with other chapters such as health systems. Then it has linkages with health efficiency, it has linkage with evaluation. We are discussing in different units as well. We will also present a tree map for it as well, how all are linked. So, at this moment I will be happy to address the equity in healthcare. I will discuss on the equity and their definitions. In the previous lecture, I told you that it was on supply side perspective of healthcare, how supply side are explained. Here we are mentioning on the types of equity as well. I mean, this picture we have taken from this site. We have also cited it here. It is not of our own design, but one clarification is very clearly understood through the graph, that equality means the exact equal share. However, the marginalized one, even if equal amount is provided, is not getting the benefit. That category has to be further re-emphasized. Hence, unequal treatment is required. And hence that will be called equity. Disproportionate share is defining some level of outcome equality. Again, outcome equality might not be possible if we have some horizontal equity versus vertical equity issues. We will clarify that. But in reality, what happens, there are 2 aspects. But the extreme best possible is the one where you just leave everything is free. The person at the end called liberation phase, where all are just watching the match or in the stadium without any fee, as if the public policy is too active enough to actually guarantee the best outcome and the freedom, etc. No question of barriers are attached, which is considered to be the new liberal policies. However, it is very difficult to guarantee, given the fact that there are lots of challenges and conflicts within the society. Hence, there should be some public policy capture. But in reality, through the public policy capture, somewhere the elite capture possibilities are emphasized. Elites are actually somehow occupying the space, and the reality, the elites are actually still climbing and getting the best benefit of the public goods. So, in this, given this context, all the concepts are meant. We will introduce you with the equity concept through different articles. We are actually not just clarifying the concept on our own, we are actually citing the articles. The first terminology is equity refers to the principles of fairness and justice in the distribution of healthcare resources and opportunities. It ensures that all the individuals, regardless of their socioeconomic status, ethnicity, gender and other factors, they have equal access to healthcare services, and hence they receive the same quality of care which you have just discussed in the diagram. Okay. So, equity measurement is focusing on how fairly healthcare resources are delivered. So, fairer distribution is one of the motto of the equity principle. In countries, government funding of healthcare or government regulated funding in allocating resources is considered to be the one of the fairest approaches of guaranteeing equity. However, allocating resources considering the differences in needs in different parts of the population is must, which is usually made in government or public policy agenda. The most common approach based on population need factors such as age, gender and morbidity are important. Okay. The allocations are made based on the proportionate to the measures of their need, and this approach is done in terms of weight of the funding towards those with worse health conditions. Okay. And hence after that, there are some problems actually raised. We are going to clarify. It is not clear that the appropriate level of funding should be proportionate to a particular measure of need, or that is rather creating further divides in the society. We will clarify. This demonstrates how challenging it can be to implement the objective to generate vertical equity and horizontal equity. Hence, we will actually clarify this, what is called vertical equity and horizontal equity. The vertical are the one where actually we will give unequal treatment to the unequals. Okay. So, now in a society we know that it is fractured in different forms by their religion, ethnicity, by their culture, and hence they should be since they are unequal, they should be actually unequally treated. Especially so far as standard of living is concerned, there are unequals and hence unequal treatment should have been given. That is precisely called vertical equity. Coming to horizontal equity, it is called just equal treatment to the equals. Those who are equal, we have to give on the basis of religion. Same religion should be given same status. Okay, even within the same religion, there are also divide, but it is not capturing in the horizontal equity principle. So, hence it is not clear that the appropriate level of funding should be proportionate to a particular level of need or not. What should be the right one? In principle, this is easier, but putting it into practice is not so easy. So, there are some in our next lecture, coming lectures, we will emphasize the practical aspects as well. So, in the perinatal mortality rates in an example, this refers to perinatal refers to the time period of pregnancy and post pregnancy related mortality. As per WHO World Health Organization's definition, perinatal mortality is the death of a baby between 28 weeks of gestation towards or before the first 7 days of life. In that case, we are just clarifying between rural context and urban context. In the rural, you will see it is quite the rates used to be very worse, whereas little better. I mean, less rates of these perinatal deaths are less than rural in urban areas. The cost of lowering the rate is higher in rural areas because of the other reasons, like service users are usually most costly to reach, whereas in urban area this is less costly. And the focus actually here through this example will actually emphasize in terms of reducing the difference between these two. Okay. So, out of a budget we might do less to lower the number of deaths in rural area, and might in urban area might do more or more to lower the number of deaths. So, in basically in the target might be since in urban areas it is 100, whereas in rural area it is 80 given the expenditure. So, but this has a dilemma in terms of policy makers or for the policy makers. This prevents more deaths by spending on the urban areas though, but at the same time the disparity actually again becomes wider. So, urban area used to be attractive with higher spending, and so that though in terms of that deaths, these kind of deaths are actually prevented, but actually gaps again between these two actually increased. Everyone likes to see both fewer deaths and less inequality, but there are many questions making this very difficult choice between a more efficient intervention, that is fewer death, and a more equitable one. Is the additional fairness worth 20 deaths, and how the expenditure to be allocated is the major concern. Another example is taken from England case based on their experience in urban area. This is owing to differences in referral rates. Poorest part of the district in England used to have the highest rates of treatable coronary heart disease, that is getting and getting less treatment because of their locational disadvantages. then the most prosperous parts in England. This leads to least capacity of the benefit, and then we're actually getting more. Though basically the prosperous parts basically are the least capacity to get the benefit, but actually they are getting more. Those likely to benefit actually got very less, hence there are possible differences again. In this case, allocation of resources is indeed inefficient. More improvement could be achieved with the existing budget by different allocation, and a greater efficiency would also lead to greater equity. Hence, the efficient allocation would actually result in better equity. Being ill or at risk, a necessary condition for being able to benefit from the treatment. Often those who can benefit most and with low income or above average morbidity, etc. In some cases more expensive or to treat poorer people, and they may also need longer time in hospital, higher cost of running prevention program for poorer people. Those choosing to attend for screening program tend to be those who are richer and have less disease, and so on. There are different examples we have cited and different context. I am not emphasizing much. Above two examples shed light on several aspects of equity which are said based on their stratification of their standard of living. There is no simple definition of equity, hence it is also important to consider equity in health sector, since it is complex, and then only we can able to clarify their overall equity. Again, another factor in addition to this problem is poverty, that again affects the ill health and constraints in access to health care. So, access to improve equity in actions to improve equity in access to health services can help, but it tackles symptoms more than the causes. The problem of health equities is largely a problem of more general economic and social inequalities, and the solution lie outside the health sector, because it is not just only the health sector that matters. Other aspects in addition to the health sector who are connected should also be dealt, such as poverty associated with poor health, and countries with great social inequalities, as I already mentioned, are also attached more conditional factors. The rapid changes in Central and Eastern Europe from the 1990s onwards were associated with rapid increase in income inequity and worsening of health. So, countries with state funding or social insurance funding would aim to provide nearly equal access, okay, to important services. I think if you remember, some of the countries have the mandatory public health provisioning in healthcare, they have nearly equal access. Whereas, when both the parties are actually functioning, private and public, the equity concern is more. Normally, state should offer care on the basis of need and not income or ability to pay. So, reality, which I already say, is often different because of some captures in the country. The users used to have some bargaining power with the providers based on their power, and they I mean the provider used to be sometimes rude to the people who are at the bottom sections of the society, and sometimes they are not getting the access as they deserve. So, the design may be equal access, but the reality is that those with more money power get better access. Hence, as I told you, elite political capture has more reasons to explain the inequalities or inequity in Indian context. Even equity principles are taken off in different programs, but eventually ended up with inequities. So, in India, access not just depend upon just one classification of differences, rather based on holistic differences such as income, employment, age, disease, caste, class, etc. And other things I think I have already mentioned. I am not specifying much on this. So, a common principle is do to others as you would have them do to you. So, you contribute and in return you will get the better one. Greater equity will be achieved only at the expense of worsening the overall level of health. Um, Equity, like most desirable ends, has a cost as well. Different philosophical perspectives on equity. Some of them we also discussed in our other weeks on like Rawls theory of social justice, and in particular in week number 8. Okay, and Sen's theory on equality in capabilities. I can refer to that here as well. Then another one is also called utilitarianism and others, suggested by Smith and Norman 2011. We'll discuss these details, some of these details in week number 8, as I mentioned. This Rawls theory is considered to be a elegant formulation and doesn't require people to care about each other, and even works better when people are highly selfish. Okay. So, some of the things will clarify further without delving into the philosophical debate. The following 3 steps would clarify the concept of equity. First, there should be some distinction between equality and equity. We started explaining through that chart from the very first page. And something is unequal doesn't mean that it is considered inequitable or unfair. For example, people born with disease or disability will tend to use more health services than people without illness, giving rise to unequal utilization that is not necessarily inequitable. Amongst people who are born with disease and disability, richer people use more health services than the poorer people. Inequity, equality as inequitable. Okay, because inequality is mentioned as inequitable. Not just looking to see how unequal something is across population groups, such as across rich or poor people or across different geographical regions, rather interested in determining what is the fairness of any observed inequality. Those should be actually emphasized. So, first what we mentioned is basically clarifying equality versus equity. Second one is in terms of sense, terminology is what is the thing that health policy makers seek to distribute equitable. What is that is more important? Is it access to healthcare, or is it actually the actual use of healthcare, or it is actual health outcomes? So, the actual use, just provision is not enough. The actual use and the specific outcome is to be also guaranteed so far as equity is concerned. So, these are common equity goals in health policy. It is not just not unusual to find more than one of these equity goals espoused by national healthcare policies. As mentioned, providing equal access to healthcare will not give rise to equal utilization of healthcare or equal distribution of health. That is, unless everyone has the same initial health status and the same capacity to benefit. So, the starting point of healthcare and this position is important if you are actually treating them as equal through the equal distribution. But large in Indian society, in my understanding, it is actually since distributed and the base is different, hence unequal distribution is important. Similarly, other things like equal utilizations of healthcare will not necessarily yield an equal distribution of health. Okay, so you can just follow some of the works we have cited. A large number of literature in health economics that is concerned with measuring access to healthcare, the lack of clarity in how access is defined and how it should best be measured should be also. The third one beside the first two which I was just discussed, second one is the sense emphasis on the thing which we are emphasizing. Third one is related to vertical versus horizontal equity. Unequal to the unequals, as you already mentioned in case of vertical, or in the horizontal is just the reverse, equality to the equals. So, equality in the treatment of people, that is people in different regions, different socioeconomic groups, males and females with equal needs should be treated equally. Okay, like for example, if healthcare resources have been distributed across a country, all people will have the same level of access to healthcare. Whereas in case of vertical, unequal treatment to the unequals, where people have unequal needs for healthcare, the treatment will be appropriately unequal. So, no need to give further examples, I think it is mentioned, you can follow it. Whether the focus should be on the first one, that is horizontal, or the vertical, the analyst requires some means of measuring and controlling for the healthcare need, and that to be discussed based on the appropriate data. A need could be defined in terms of scale of suffering and health problems, or in terms of capacity of the benefit. So, anyway, we have given you the basic backdrop of the difference between equality and equity. So, in the next class, we will be happy to address you further details on it, measuring aspects of measuring tools, or suggestions for equity and equality. So, we will be emphasizing on some theories of equity and redistribution, then traditional model and their problems and their theory of distribution. Other theories of distribution and their problems would be emphasized. With this, it is time to close. I think we will be happy to get better things in the next class. Thank you.